Mr. Amod Gupta, who is not only uveitis specialist but one of the finest retina surgeon in India, and he's trained so many retina surgeons. And all of us, when in trouble, then we go and ask him to bail us out of the trouble.
Thank you, Dr. Rupesh. I think I'd like to just add to this comment on azathioprine. You know, it's a much maligned anti-metabolite, and reason why people are asked to not use it is because of the GI disturbances and intolerance issues. And a recent study from, I think, from the US has shown that this is the most intolerated immunosuppressive agent. And I thought we have the maximum experience of using it close to more than 200 patients, and I didn't see the kind of side effects which they report. Almost like a quarter of patients have to discontinue the use. So in our population, probably the side effects are less, GI tolerance is better. So there may be regional and racial and genetic issues to the tolerance of the drug. We don't know, but this is just an idea because the way they describe in literature, I don't see it in my patient population, and they find they are tolerating much better than the most of the reports. Anyway, we'll come to now this issue of vitreoretinal interventions, and what we have learned over these past few days, that the medical treatment which we have been hearing is very effective, very efficient, and essentially what you need to do is douse the fire using corticosteroids by maybe intravenous routes, maybe topical routes, or periocular or intraocular. You need to control for immediate use. Till date, there is no better substitute than corticosteroids, as 1950 when mentioned, Dr. Gordon introduced, and for the last 70 years we are looking for an alternative. We don't have an alternative corticosteroids yet. And also just now he has elaborated in great details that how we need to maintain or we need to achieve a steroid-free remission, or if not possible, we need to bring it down to well-tolerated dosage of corticosteroids. Just to mention, 8 milligram is the maximum tolerated dose of corticosteroids for long-term use. More than 8 milligram per day, if patients are taking, they have a high risk of avascular necrosis of the hip bone, the femur, neck of the femur. So just remember that. Of course, the other side effects, I'm not going to go into that. Now, we need to manage surgically these two complications, the cataract and glaucoma. So I'm sure everybody is aware that patients do get early cataract in uveitis patients, and they also get secondary glaucoma, which is very difficult, very challenging to manage. And very recently we have 2 papers from our group dealing with these 2 situations, how to manage cataract and glaucoma in those experience. Now, why vitreous surgery in patients with uveitis? So I can divide that into 3 main groups, where it is therapeutic, is diagnostic, and where you can combine the 2, diagnostic as well as therapeutic. What might be the common indications? These are very common associations, the complication that we see, long-standing inflammation in the eye, especially in the posterior segment, and vitreous would lead to these membrane formation, a lot of vitreous hemorrhages, or the fibrous scar tissue, and sometimes you have to combine vitreous surgery with complicated cataract surgery. So these are the common causes. Now, when we are trying to evaluate, remember the spectral domain OCT is far more sensitive in picking up these membranes on the surface of the macula. So rather than a patient not improving vision following inflammation, and you are wondering and you are trying to force more and more therapy in terms of injections or more higher dosage of steroids, hold back. First, clinically evaluate the patient and do simple strategies like I told yesterday also. Do an OCT, okay, and see, and specifically do a spectral domain OCT to see if these membranes or fibrous tissue on the macula is preventing the visual recovery, and rather than push in more drugs. So you should see what is the cause of the visual loss. Any one of you remember this patient I had shown yesterday? Yeah, you recall? When we were discussing acute retinal necrosis. So this guy went on to develop as he was healing. These are the healing lesions here. Okay, so we did a prophylactic laser because at that point of time, there was a lot of enthusiasm to prevent the occurrence of retinal detachment in patients with acute retinal necrosis. The other eye, we did not do prophylactic laser therapy. Okay, and what happened was exactly the opposite of what we thought we will achieve. So this eye, with the prophylactic laser photocoagulation, went on to develop a retinal detachment. So this is where it developed. He came back with loss of vision because of retinal detachment. The other eye, which we had not done prophylactic laser, didn't have, all through his life, didn't have any retinal detachment. So this had to be fixed. And these are very, very challenging patients. And majority of them would develop almost to the tune of 70% of these eyes will go on to develop retinal detachment. So there is a view now emerging that maybe we should do a prophylactic vitreous surgery, because these patients tend to develop retinal detachment when they develop posterior vitreous detachment. When the vitreous is detaching, it breaks into this area of necrosis. And I told you that these are sieve-like, here these sieve-like breaks will occur, very difficult to close them during surgery. So prophylactic vitreous surgery is one which is done by several people to remove and do the, under controlled environment, remove the posterior hyaloid from the retina, so that these patients will not develop retinal detachment. Because once they develop retinal detachment, this guy was very lucky actually. He returned 6/6 vision, following this surgery, and of course the cataract surgery is the right to go. Now other patients are like this. They would present to you in this kind of situation. You don't know what you're dealing with. In fact, these are the cases which complicate retinal vasculitis. So when you have retinal vasculitis, unlike choroiditis, you have issues with fibrous proliferation, you have issues with neovascularization on the disc or neovascularization on the retina, and they are all accompanied by scar tissue which contracts, pulls off, and you can see so much scar tissue here, and this has to be meticulously cleaned up during surgery, and you can return actually, like in this patient, we could return out again very practically normal vision. Or an example like this here, again you can see the visual recovery sometimes can be limited because of the subretinal fibrous scar tissue which is seen. Now he had a lot of scarring in front of the retina in the vitreous cavity and also under the retina. So these are rather complex issues, and this is how they go on to develop. Like a patient, he has a scar tissue forming here, a lot of traction in the macula, vasculitis here, scarring, and then we find that he develops within a matter of 10 days. This guy comes back from a normal vision. Now the vision is lost because of the hemorrhage that has occurred. But these are the kind of patients who do very well following vitreous surgery. I'm not sure how common you see these cysticercus, which could be in front of the retina, behind the retina, anywhere, and they also need to be surgically removed. Now, another indication which I alluded in the morning very briefly was hypotony. Now, this is an issue with, if you have a delayed diagnosis of juvenile idiopathic arthritis patients, that they will end up with chronic hypotony, which is a pressure of less than 6 millimeter. Apart from several other reasons, chronic uveitis in these children would be an issue. And how they manifest is disc edema. They would have a macular fold, and they may even go on to thysis bulbi. Now, we always associate low pressure with uveitis, with inflammation, except in patients with viral uveitis, which I said have high pressure. Okay, so that's a pointer to viral epidemiology if you see high pressure. But otherwise we have low pressure. And this, if it persists, if it is lower than 6 millimeter and it persists, the reason is these formation of these epiciliary membranes, which we have known as cyclitic membrane. Have you heard of cyclitic membranes? Okay, these are very, very dense, thick fibrous scar tissue overlying the ciliary body and over the pars plana, and they could be on the ciliary processes. So if they are on the ciliary pars plana, then probably we don't know much about it. But if they are on the ciliary processes, they cause traction, and they cause tractional detachment of the ciliary body. And you know, if the ciliary body is detached, the pressure of the eye goes down. So this needs to be surgically settled. You know, you need to remove this epiciliary scar tissue from the, and this is a challenging surgery because you have to do it under direct view, and you have to do a lot of scleral depression and use bimanual techniques, you know, use a forceps and a scissors, and these are big chunks of fibrous tissue you want to remove from the ciliary processes, and I'll show you a few examples of these cases. Now, ciliary process over a period of time, because the inflammation, they could become atrophic and become blunt, and ciliary processes are the ones which are responsible for aqueous formation. So if they are blunt, they are, you know, kind of atrophic, they will not produce aqueous secretion, and the pressure will persistently remain low. So I'll show you a few examples. Like this is one, when we talk of the ciliary, epiciliary membranes, you can see not only is this blunted here, but it's a thick membrane. So it will need to be surgically removed, and the patient has just 5 millimeter pressure, 4 millimeter pressure here, bad cataract, synecdoche, and like here. So in these kind of situations, when the eye is hypotenuse, there is no point in putting an intraocular lens implant, because here we are looking for providing, rehabilitating them with ambulatory vision so that they can walk on their own. So we are not looking at providing, restoring a normal vision. Okay, so in these kind of hypotenuse size, we don't ever think of putting an implant. Okay, we were lucky in this patient, we could restore very nice vision, which is extremely happy. Now this is another patient, he's 14 years, and he has that, what I was talking, seronegative spondyloarthropathy. He has that acute anterior uveitis, but has had recurrent, recurrent attacks, and which were not managed well, and you can see that how bad it looks. Now this is scar tissue, this is not cataract. So when you're removing this, you have to separate this, okay, and when you start separating it, this comes off as a fibrous membrane, and underneath you find a cataractous lens, okay. So this is how the contracted fibrous tissue in the pupillary plane looks like, and then you do an ultrasound and you could restore. These patients, we like to use posterior subtenon triamcinolone, and I would inject them rather anteriorly rather than posteriorly, because here the intention is to use the side effect of triamcinolone on the eye to raise the pressure. So we know that triamcinolone is notorious for producing glaucoma. So here we want to raise the pressure. So rather than give deep posterior, I will pull it anteriorly and give it there. And I would give them repeatedly, and in my armamentarium, this is one very good indication of giving triamcinolone when you find the eyes have low pressure. Okay. Another, you see this is the kind of patient, so dense peripheral synecdoche, and these are the patients who are given up as blind. Some of these children we used to see, they are blinded, and nobody cares for them anymore. And you can see the destruction of the ciliary processes on UBM. So when you are evaluating a patient of hypotony in uveitis, I think if you have the facility of doing by microscopic examination, UBM, which is an ultrasonic technique, okay, so it will tell you the health of the ciliary body. That's what we are concerned with in these patients. Okay, and sometimes you can come out. Now you see this on ultrasound. This is the right eye. You can see already the axial length is small. So some of these children would have 14 millimeter axial length, 16 millimeter, and if you ask somebody, they'll say this is now atrophic bulbi, atrophia bulbi. The eyeball has shrunken. Do they have potential for vision? Yes, sure enough, they have potential for vision, because these eyes, depending on how healthy is the ciliary body, which in this kind of here ultrasound picture, if I see this one, I know this is already becoming quadrangular. Okay, so somebody asked you the signs of hypotony. The quadrangular eyeball is a sign of your atrophic bulbi. Now, in this patient, I expect ciliary body to be practically dead, non-functional. So we fill it up with silicone oil, heavy silicone oil, which to restore the volume of the eyeball as well as helps to restore vision. So some of these patients, like this is the right eye of this patient, and the left eye with silicone oil here. So person who has light perception or less than light perception vision, if you restore them to 2000 or 2200 or 2400, it's a great vision for them, because now they are on their own ambulatory vision. So several years ago, we published in Retina this paper where for the first time we showed that depending on the UVM findings, if you are intact ciliary processes, then from preoperative pressure of 4 millimeter, we could restore, go up to 9 millimeter. If we inject silicone oil in patients with ciliary processes atrophy, from 3.7 it went up to 11.53. The problem is that if we don't inject oil and there is a ciliary atrophy, okay, and no oil we put, the pressure actually goes down. So UVM plays a very critical role in our surgical planning. So now these were some of the therapeutic indications for vitreosurgery or vitreoretinal procedures. So I have just given you a brief outline of that. Now coming to the second aspect, and these are where we combining diagnostic and therapeutic. Like this female patient comes to us with history of fever, and she has received dextrose infusions, parenteral infusion during her sickness, and she presented with this kind of picture. A lot of cellular reaction behind in the anterior vitreous. There is a hypopyon, there is intense inflammation. What do you make out of this? What is it? Any guesses? Endophthalmitis. So now, clinically, we can guess that this patient has been sick, was admitted in a hospital, received parenteral treatment. So our likely guess is that this patient has endogenous endophthalmitis. But speculation will not. We need to show what is causing, what organism is causing them. Okay, and so it was in this patient, and you can see here, this is what it looks like. Following the vitreous surgery, now we see the abscess sitting under the retina, which has broken into the vitreous, causing all that, and there is a calcofluor stain, and it grew aspergillus flavus from both the eyes. Okay, and finally we could salvage this eye by doing a very timely diagnostic therapeutic, because it's very difficult to eliminate fungal elements from within the eye. If it is post-surgical fungal endophthalmitis, it's very, very challenging. In endogenous fungal endophthalmitis, we still have better outcomes. But if you don't do vitreous surgery and are happy with diagnosing fungal hyphae by a vitreous tab, and you don't remove the vitreous by vitreous surgery, these patients are never going to respond to any of these therapies. So here we combine vitreous surgery, we diagnose it, we combine with oral antifungal agents like voriconazole, which will be given for several weeks. Personally, I would give them for almost like 3 months. Even then, they can recur, especially in post-traumatic, post-surgical fungal endophthalmitis, they would come back in 6 months, they will come back again. Endogenous, if you have taken care of by antifungal agents given for 3 months, I think they are good. Now, this is another situation. Now, this is a 26 years old woman. She presents like this, and she is a case of Crohn's disease. You know what is Crohn's disease? It's a part of the inflammatory bowel disease. They have ulcerative disease in any part of the intestine. Okay, and she had this picture for about a month. And typically these patients would require parenteral nutrition because they are not able to digest. Okay, so she has been on parenteral nutrition and now she presents with this. Right? So how do you diagnose? So we know that there is an abscess sitting right there. This is an abscess. There is no uveitis. Okay. So what we do here is go again and do a vitreous surgery, and we find that this is within 4 days. You can see how everything could be removed, and we know from where it came. Okay. And of course, the patient had expansion of the scar tissue over a period of time, but ultimately did very well, 6/9 vision. And we got the organism here, streptoneumoniae, which was treated with antibiotics.
Choroidal abscess.
Yeah, choroidal
So you
abscess.
went below.
No, we removed all this. The abscess sitting here, we did just probably the source from where it started, originated. Right? This I have shown you in the morning. Okay. Now the point is, when you see cells, okay, typically we'll see cells in the anterior chamber or in the vitreous cavity. Now this could be immune mediated, like we have been discussing, non-infectious uveitis, or these could be infectious, like we have been dealing exogenous or endogenous, and it could be viral, fungal, bacterial, number of agents, parasitic, or they could be malignant. So we have seen all these. So we need to, especially in patients where we are not able to make up our mind, what are we dealing with, we need to look at these cells. How do we look at cells? Obtained by biopsy. Typically in the anterior chamber, unless you have a hypopion or a large collection of cells, we will not get adequate sample for making up our mind. So we don't do surgery the first go. When we want to do a diagnostic surgery, we don't do it right on the day one. Okay, we wait for a few days. So I have shown you example in the morning of atypical clinical presentations, non-responders. Okay, then we have instances with this rapid progression. You do a lab workup which is non-invasive and doesn't yield any results, and we know that this patient, if we allow it to progress, will become blind. So these are the kind of emergency situations where we need to do a diagnostic surgery. And then very strong suspicion of malignancy. So these are the characteristics where we want to do a diagnostic. Before we do diagnostic surgeries, we need to have a very clear plan. Okay, and most important is that experienced cytopathologists must be aware. We don't do any pathological, any invasive procedure unless I'm sure that my cytopathologist is available at that moment. Actually, when we are doing the surgery, the cytopathologist on standby. He's not even asked to have a cup of tea or coffee. We tell him, okay, my sample is being rushed to you now. Okay, typically labs would be located away from the operation theaters. Okay, so people have to run. Actually, we have a car standby, we have the guy standby, we take the sample in a cold bucket, okay, so that the cells don't degenerate by the time they reach the cytopathologist. And if that guy is having a cup of coffee or busy somewhere, such a big invasive procedure goes waste. The cells degenerate. So we want to preserve the health of the cells. Okay, everything will go to naught, if we don't take these precautions. Okay, and of course the consent of the patient that we are doing this for this purpose. So we are not doing any of these things just for fun. Okay, so we have to be very clear. So we can do a variety of tests on these. Microbiological tests we can do polymerase chain reactions, we're hearing about these, we can do cytopathological, we can do, flow cytometric. If you have a trained immunopathologist available and you have the lab where they have flow cytometer, they can actually identify a lot of these markers on these cells and tell you exactly what those cells are. And typically you will need these flow cytometric analysis for lymphoma cells and others to tell you about whether they are the polyclonal or monoclonal. And then we can, I've shown you now also that we can do cytokines. So I've given you example in the morning. And of course we can look at we alluded very briefly yesterday that antibodies can be checked. Typically we'll do it for toxoplasma or for rubella. We'll see the level of antibodies in the aqueous humor versus the serum, and if there's a local production of these antibodies, like in toxoplasma, this is what we call Goldman-Whitmer coefficient, DW coefficient. If it is 3 times the serum levels, we know there's a local production of antibodies, so there is a local infection. Now, TAP is personally I don't do. I do TAPs only where I have already done vitreous surgery, removed the vitreous gel, because when you aspirate on this, you cause a lot of the gel which gets dragged. Okay, when you pull on the gel vitreous to a narrow needle, you tend to cause traction on the retina. In many of these cases where media is hazy, you don't know whether you have a necrotic retina in the periphery, and you pull on it, in your enthusiasm to get, because you will have a dry run, you don't aspirate anything. And you pull more and more, and you might pull the entire retina into and a necrotic retina would easily tear. So for those reasons, I am not doing vitreous tap unless I am sure of that there is no gel in the vitreous. If at all, you have to do, and that is true even for anterior chamber tap. The material which comes is so little, okay, you will not be able to push it back on a slide. So what we do is, we keep some normal saline or vinegar lactate or some fluid in this syringe. We fill it beforehand. Okay, tiny amount of fluid, so that when you aspirate, whatever cells come, they come into the fluid, and you will be able to recover them, later. So I have told you enough reasons why we do vitreous surgery. I don't need to go into. Now, some smart people would use tissue culture medium. I told you that the cells have a tendency to degenerate during transportation. So some smart guys, would use your microbiologist or your cytopathologist will give you tissue culture medium. Okay, this is the culture medium. You keep it in the syringe in which you are aspirating the material, collecting these cells. It will save you the material. But per se, vitreous surgery cutter does not cut these cells. Okay, so no worry on that count. So you don't need to really go into the details how to do this. I'm sure once you set up a facility, your cytopathologist will tell you more. So if you don't have immediate access to the cytopathologist, you should keep these cells material at 4 degrees Celsius in a refrigerator. Okay? And you want to fix, sometimes they tell us, okay, buddy, you fix it right in the operation theater, use alcohol, 95% alcohol, and fix it. So we can prepare that slide and send it to the cytopathologist. So microbiology, cultures and smears, and and there are various ways where you collect in the chamber of the vitreous surgery machine. You have a lot of fluid, and we don't want to waste that. We don't throw it in the trash bin. Okay, we like to filter it using micropore filters, so that they will have all the cells trapped into the filter paper, and then cytopathologists can cut those discs into, and use it for staining. And of course, we use a lot of these for molecular biological techniques. Now you need an expert. I, as a ophthalmologist, will not be able to tell. These I've shown you the cancer cells, the retinoblastoma cells in the patient I've shown you, and this is something like open keratin here, the chromatin. This is malignant cell, melanoma, and the lymphocytes. So these are the malignant cells. On our own, we'll not be able to tell. Okay, so no point unless you have a cell pathologist. And so is these inflammatory cells. Now, how do you tell from activated? I think I use that word reactive lymphocytes. So, how do you tell whether they are activated or non-activated? By the staining characteristics. So, activated T cells are very, very intensely stained, okay, compared to non-activated lymphocytes. Then, you know, the neutrophils, the eosinophil. If you see eosinophil in your smear, you are sure you are dealing with a parasitic infection, okay? And of course, you can see these macrophages here, okay? And these are the macrophages carrying the DNA of the mycobacterium tuberculosis, and unless your aspirate has cells, and macrophages in particular, your PCR will be negative. So this is toxogranuloma. Now, I shown you this picture yesterday. Remember? Any one of you? So this was a patient who turned out to be HIV positive, and we were discussing acute retinal necrosis and toxoplasma when we were having discussion on retinitis and how in HIV there could be. And the question I posed to you was, what's going to happen to this patient? No? Did I ask that question? I did. Okay. So what will be the outcome? So the point is, why the outcome is important to know that if our diagnosis of an infection is right, and we institute a very specific antibiotic or specific therapy for that, okay, we must see the outcome, whether it responded or did not respond. So in this patient, you see the response to treatment. Necrotizing because of VZV and toxoplasma and the both eyes. You can see now excellent response to after you made the diagnosis. We'll go on to our next patient, and this patient is 65 years. She has never been operated in the eye, and she says that I have decreased vision in this eye for the last 2 years. Okay, and what do you think is the reason? What is the first thing you're going to see in an old person who presents with this kind of picture? So I told you that 65, we are already thinking why inflammation in this patient at this age. So we think of the masquerades. Is this patient having primary vitreoretinal lymphoma? That's the first thought. Then I also told you and discussed in the morning the endogenous endophthalmitis. Is this patient have endogenous endophthalmitis? Okay. Now, before we jump to and start looking for those two things, we need to look at in a person, and I told you that this patient has not undergone cataract surgery. So in your clinical exam, have you paid attention to the presence of the lens? Where has it gone? We did not find any lens. This is aphakic. So what do you do next? We can do what? Rescan. Very nice. You guys are so smart. So we look for the missing lens, and there we find the missing lens is lying here. Okay. So now it is so simple that we are dealing with an old woman where there is a spontaneous dislocation of crystalline lens, which is causing what we call as phacoantigenic uveitis. Okay. Now we need to remove this lens. Okay. So this discussion normally you would have with cataract surgeries, where they do a nucleus drop, or they have a soft particle matter which drops into the vitreous cavity during phacoemulsification or the cataract surgery. So this kind of discussion, why it needs to be removed before the onset of inflammation. But when it is happening spontaneously, you need to remove it because they have already caused a lot of inflammation. And we did that, and you can see this, the pap smear is showing a lot of these foamy cells because of these macrophages, the phagocytose, the lens matter, they become swollen, they're large, okay? So this is a lady, or this is a gentleman, sorry, and he's presented with a lot of inflammation. You can see the hazy media, right eye is hazy, left eye is less hazy, but there's vitreous inflammation. We have absolutely no clue. But when we ask for history, the person is HLA-B27 positive. So what have we learned about HLA-B27? It causes, what is it called? HLA-B27 acute anterior uveitis. So acute anterior uveitis, it doesn't cause intermediate uveitis. Okay, so now it is not, it's confusing us. How come a patient who has HLA-B27 has intermediate uveitis? Okay. Further quizzing him, he says, well, I have been treated for pulmonary tuberculosis 2 years back. Full course treatment he has taken. We further ask him, he says, you know, I have blood in stools. We examine him, he has hepatomegaly. He has splenomegaly. He has ANA positive. So when you have the entire spectrum of labs coming positive, does it help or does it confuse you more? So in this setting, what would you do? So here is a situation with atypical presentation. So first thing I want to know, is this guy immunocompromised? So I like to do HIV. Okay, we did that, the HIV is positive. Now does it help us or doesn't help us? So we know that most likely we are dealing with a patient who has infective uveitis. So no way I'm going to treat this patient on corticosteroids. So what do? We test for, say, syphilis. That will be the first thing in mind, because syphilis and HIV, they go hand in hand. Okay, syphilis is negative. So what you do here is, now this is the time that you want to make a definitive diagnosis, and we do what? Diagnostic PPV. We go in, okay, clear the vitreous and send for all those microbiological tests and examines, and we found that this patient had PCR positive for HSV. And this is what treatment is easy, I tell you. Treatment is not confusing at all. Once we know the right diagnosis, the treatment we know. And this is what, was treated for 6 months, and he absolutely fantastic. Okay. This next patient I have shown you, so we'll skip this. So I have shown you similar cases in the morning when we were discussing the masquerades. It is again one of those patient who's presenting as vitreitis. Okay, and first thing we look for in these patients of intermediate uveitis is clinical exam. What are we looking for?
Intermediate uveitis.
Yeah, intermediate. Intermediate uveitis is when you see The maximum inflammatory cells are in the vitreous cavity. Okay, more than a clear chamber or more than the posterior sectional pathology doesn't explain. But when we see intermediate uveitis and there's a lot of activity there, first thing we want to do is indirect ophthalmoscopy with scleral depression and look for in the inferior pars plana, is there snow banking? Okay, because that will give us the diagnosis of pars planitis. Okay, so if we see those dense white, deposits, and they become fibrous and they become cyclic membranes, they are in the pars plana region, they are very dense deposits. Okay, and they get vascularized and they also lead to vitreous hemorrhages, recurrent vitreous hemorrhages come from there. They can also cause traction on the retina. Now this is the spectrum of pars planitis, which can be associated with multiple sclerosis, optic neuritis, and that spectrum. So 10–12% of them will have multiple sclerosis. So you want to exclude that by examination. And if we see pars plana exudates here, pars plana deposits, and snowballs or fibrous scar tissue, we know we are dealing with the autoimmune disease. But if we don't see that, then it could be because of TB, it could be because of sarcoid. I've just shown you an example where it was because of the viral infection, it can be because of syphilis, it can be, then it's doors wide open for the possible etiologies. And one of the examples I've shown you in the morning where it was of PVRL or the primary vitreoretinal lymphoma. So that also can be seen in this context of intermediate uveitis. So I've discussed this, that you can see syphilis, tuberculosis, sarcoid, they can all present. And these can, now one thing I want to emphasize very clearly, that in my lifetime I have focused only on clinical exam. Clinical exam followed by imaging techniques if they are available, and now we have a variety of these imaging techniques. Earlier we used to have fluorescent angiography, then came the ICT, then came the OCT. Now we have the OCT angiography, we have the fundus autofluorescence. These will tell you a number of structural and functional components of the inflammatory diseases. And once you have gone through these, and of course aided by ultrasonography when video is hazy, or even when the video is not hazy, doing the UBM, completes my workup which I can do in sitting in my own clinic. Okay, so I don't even start writing for the labs till I am very sure what am I seeing clinically. Okay, because if you don't follow that route, the labs will confuse you more. And here is another. So the labs have to be interpreted in the context of what you are seeing. And this is again, this patient, it confused us. Because in a TB endemic country, TB test is positive every other person. Okay, so this is how it got compounded. 23, so necrosis here. So is this vitritis caused by tuberculosis? Sure enough, it could be. But there's no response to steroids, no response to anti-TB drugs. And that is when your antenna go up. And you say, well, this patient is not responding. If it were because of TB, it should have responded. If it was sarcoid, it should have melted away. They're extremely sensitive, sarcoid extremely sensitive to steroids. You should see the response within a matter of days. It didn't go. So what we do, we go again, do a diagnostic surgery, and lo and behold, we have again the lymphoma diagnosed by cytopathologist. So I think now you're getting the hang of how we approach these patients. Is it? Or is going over the head? Someone? Huh? Well, I'll show you a patient here. Now, what are the situations? We are talking of where they are not responding, they are not conforming to the clinical spectrum that we know, and they are not responding to the usual treatment. Now I'm going to show you examples, couple of examples of patients who are, despite our treatment, they are progressing and sight is threatened. So I'll show you this young girl, and luckily or unluckily I need to harp on the TB theme because maybe that's the way the patients come to me. Now this young lady had a skin test positive. This is what we commonly do, tuberculin skin test. You're highly positive. And she was, the person who was seeing her, he very nicely ignored this test, and he saw this lesion, serpiginous choroiditis, and he put her on 80 milligram prednisone. Now, the patient should have responded. This is at 1 month after she has received 80 milligram prednisone, and by 3 months, you can see the lesions have expanded, they are all growing big, and this is the foveal center, this is getting threatened. We said enough is enough. She has received 80 milligram prednisone, she has TB skin test positive, so let's put her on anti-TB drugs. And I think we had yesterday some discussion on paradoxical reaction and immune reaction in these patients, because this pathology is basically driven by an immune response to presence of TB bugs in the eye. Let's be clear on that. Okay, so we thought that we'll give her anti-TB drugs to eliminate TB organisms, as well as we added azathioprine to add to the immunosuppression. Okay, there's no response. We wait for 2 months. Now this patient is now received treatment for 5 months, and yet there is a relentless progression of the disease. The fovea is right now here threatened. So this is a time we say, well, I didn't have the heart to do a retinal biopsy, but we thought, let's do a vitreous biopsy. Okay, and see. And what we do here in the vitreous biopsy is, we, as I said earlier, we collect under air undiluted vitreous sample and subject it to various tests. And so was, you can see this is vitreous getting collected. And by this technique, we can collect, I could collect almost like 1 ml of vitreous, which is huge amount for subjecting to a variety of tests which you can do on this. Okay, so what we did in this patient, we subjected that to, I'm not sure how many of you are familiar with this, is the Gene Expert printout. The machine gives this printout after about an hour or so of putting that sample into the machine. So it detected MTB medium numbers and rifampicin resistance detected. Because this is used for pulmonologists world over now, standard of care. Gene Expert, for again, it's a closed system, there is no manual except you have to just put the sample into the cassette and it gives that result. So this is the most valid tool for pulmonary TB as well as extrapulmonary TB, but nobody had been doing, and sensitivity for ocular TB is very low. But it's good for detecting, like in this patient it detected rifampicin resistance, but we were not satisfied. We did a gene sequencing from our DNA amplicon. We did a gene sequencing and we found that there was a resistance at codon 526. Now this codon 526 is in the MTB genome, it's the region where the commonest site of mutation. So if there's a mutation there, the organism becomes resistant. Then we did the line probe assay. This is the third technique we used. Because why were we chasing it? Because nobody in the world had ever told that eye tuberculosis or serpiginous choroiditis could be caused by a resistant MTB. Okay, there are no reports because there is no culture available. So usual techniques are you do the culture, takes about 6 weeks to tell whether the organisms are resistant or sensitive. Now we are using molecular techniques which are now validated all over the world. Molecular techniques give you within 24 hours, 48 hours, you know whether this the patient has resistant bugs or which has sensitive bugs. Okay. So we started her on multi-drug resistant anti-TB, which consists of very toxic drugs like streptomycin, thionamide, cycloserine, okay, and we taper down the steroids. I'll just show you how this sequence looks like. This moment is my computer is hanged, doesn't like because it's 1 o'clock, so 1 o'clock it hangs. Huh? Yeah. Yeah. So, anyway, this is I hope you get it. So this is how the sequence. This is just I'm showing to. This is how these are the various codons, and we are talking of this 526, and this is just to show you how this is changed. And this codon, this is the sequence should be CAC. It's converted to TAC. Now this single point mutation is led to resistance. Now what happens to the patient? That's what our major concern is. And this is after starting the MDR treatment. 4 weeks later, patient is very good. 8 months, she's extremely good. All the lesions are healed. They were a relentless progression. The patient is healed now. Subsequently, okay, we kept on following, and this is 2 years follow-up. There's no recurrence. The lesions have all healed. Subsequent to detection of multi-drug resistance. This is just an example. This we published 2015 in ophthalmology, part of our paper on PCR. But just to show you, I'm sure you are not going to come across these patients very often, but just important to know, sometimes, like this patient, this is my last patient, just maybe 2 minutes, he's a 35-year-old person, and he has received all kind of treatments, like IV methylprednisolone, methotrexate, he has received, 360 vision because of this posterior uveitis here, he has vitritis. Now this patient has actually gone into depression. He wants to commit suicide because he's been under treatment for almost like 7-8 months without any relief, and he has been to all big time uveitis experts at least in our country. And he says they won't do it, and I'm going to go blind, so I want to die. So I said, okay, before you die, you give me a chance. Okay. So here what we did was, this is how it looks like on angiogram. You can see intense inflammation of the posterior segment. What surgeons do best is surgery. So when they are facing a challenge, okay, you take the patient to surgery, and this is what we did. Exactly the same procedure. Okay, and we thought we'll do all kind of PCRs, which we did. And we did for viruses negative, gene expert for TB was negative, but when we did a multiplex PCR and we did the sequencing, as I told you that we depend on sequencing to see if there's a mutation or no mutation, and we found, happily enough, this patient had a sensitive MTB. You can see the response, okay? Within a week, this is presenting. This is within a week, the lesions are already healing. Even before we put him on anti-TB drugs. I think Dr. Vishali was yesterday somewhere in our talk was alluding to the collection of these inflammatory cytokines in the what we call the bursa, which is the pre-retinal bursa, okay, in front of the retina. And if these cytokines, inflammatory cytokines, are getting collected there, they have an adverse effect on the retina. They keep on, in a vicious cycle, they'll keep on perpetuating, maintaining that inflammation, exacerbating that inflammation. Okay, if you remove them, okay, you bring about a reversal of the process. So this patient already is from 3/60, he has improved to 6/18 when we started him on anti-TB drugs. okay, because we are waiting for all the gene sequencing and stuff like that, and this is how he heals extremely well. This is the point when we started his anti-TB drugs, and then we followed this patient. He is now extremely happy from a situation where he was going to commit suicide. He sees life very, very colorful now because his vision that then we followed him. I will not go into the details. I'll refer you to this paper we published on the safety and efficacy of the microincisional vitreous surgery. You know, in the long time past, we used to do little clumsy technique using 20 gauge vitreous surgery. Now we have 25, 27. So it's extremely safe and effective surgeries. You get to make definitive diagnosis, and you get to change a number of patients. I don't want to have time to show you all the details. Suffice to say that you can read this paper for this, that choroidal detachment. We had a couple of patients where we were, trying to pretend what we were not. We thought our incisions don't leak. Okay, so when we are doing a diagnostic vitreous surgery in inflamed eyes, make sure your incision don't leak, and that's how we learn. So friends, intraocular inflammations that we have seen may be caused by infections, by autoimmune disease, or by malignant cellular infiltration. Clinical history, examination, disease pattern, ancillary investigation, lab work is crucial. Patients with atypical presentation and those not responding to standard therapy require diagnostic surgical interventions. Samples should be handled, transported carefully. These procedures should be done only if you have the help of expert cytopathologist, expert microbiologist, expert immunopathologist available in your institute or in your city or in your area that you can transport these. Okay. Some of these patients who need therapeutic intervention, we can really help them. Small children who have been neglected, JIA patients, complications of uveitis, need OCT. Before you push in more drugs, do a simple OCT, look at the health of the fovea, okay, and see if there is any fractional elements, fibrous scar tissue which you can remove surgically. Thank you very much, and I think this is the last talk I have to make. And thank you very much, and I enjoyed interacting with you all. And I have given you my email ID. Please feel free. Feel free. I survive on one challenge a day. Okay, so I'll help you out. No worry. Thank you.
Thank you, Professor Gupta. I think one of the testimonial I can have for that vitreoretinal intervention in uveitis is for my own cousin, who Professor saw, and we managed first cousin, and we managed for TB uveitis. You remember? Yeah, and for 3 years we had his inflammation going up and down, and all TB treatment given, and azathioprin given, and almost 3 and 4 years. Very young age, 23, 24, and finally I had to get some opinion from Professor Gupta. I sent it to him, and immediately advised that maybe at this time we should go ahead and do a vitrectomy because it was intermediate uveitis, repeated flare. And then we did. One mistake, the surgeon, not mistake, maybe this is something which we learned. It was done a sutureless thing, and the IOP next day was 0. So I think that was one, and but now he's still phakic, vision 6/6 for last 6 years, not on any kind of drops, not on any medication. His vitreous sample, as we were discussing yesterday, someone asked, his vitreous sample was sent for microbiology. PCR was positive for TB. PCR was positive for TB from that sample, but we have not given him any anti-TB treatment. He already received it, but no anti-TB treatment. So what do you think about that case? You remember?
That's what I say. I don't order labs, I don't interpret labs unless I know whether the clinical setting the patient has conforms to my clinical diagnosis. If a lab supports my clinical diagnosis, now, not only this, we have published, I think a couple of years ago, that paper where what we did, very simple thing. It's believed And there's ample proof for that, that the mycobacteria, they lodge and sequestrated in retinal pigment epithelial cells, in normal people also. So we can presume that if you have infection, like your quantiferon test is positive or your skin test is positive, it's likely that you would have these TB bugs sitting in the retinal pigment epithelium of your eye. Okay, so how can we collect these? So what we did was something rather smart. We have these patients of rheumatogenic retinal detachment whom we subject to vitreous surgery. During surgery, there is so much amount of subretinal fluid which is available for aspiration, and this subretinal fluid is so rich in the pigment epithelial cells which get shed. So we were looking at 100 patients of rheumatogenic retinal detachment, and we were doing their Monto's test. So some of those patients, I think 16 or patients out of 100 who had skin test positive. Out of these 16 patients, 5 patients we showed that PCR for TB was positive in rheumatogenic retinal detachment. So do we treat these patients with anti-TB drugs? No way. So if you do PCR from normal tissues, people have done, there's a beautiful study from Mexico where they have taken tissues from lung, liver, here and there, and they found almost 40 to 50% or even up to 70% tissues having PCR for TB positive. Okay, so it's present in a person who's infected. So we have no copy numbers unless we know exactly what are the copy numbers present. In small copies, they could be just normal hibernating or the DNA present there. So it doesn't make sense to me. So otherwise also nowadays we are doing not very commonly this PCR, but when the situation demands, we go all out, like I shown to that girl. We declared war on that. We used all possible techniques to show. Okay, and these are the 3 techniques which are available today for PCR. We did that. Okay, today's time we'll do a quantitative PCR, the real-time PCR, to see what are the copy numbers. In small copy numbers, probably they could be just present by the way, but they are high copy numbers, we know that this is causing infection. Is that?
Absolutely, absolutely. So I think you treat the patient, not the lab. That's a very standard thing.
That's the important message.
That's the take-home message if you can remember some of those things. Any questions? Chitranjan, you'll be doing vitreoretinal surgery.
What are the cases where silicone oil injection is needed in this vitreous surgery?
See, I rarely use silicone oil in my regular vitreoretinal surgery. I'm not a great fan. But the greatest fan of silicone oil for these young children, I've shown you example 3, 4, where they have ciliary body atrophy or they have cyclitic membrane, they have destroyed ciliary processes. Hypotenuse eye, I've shown you on ultrasound, they are 14 millimeter, 15 millimeter, 16 millimeter eyes. They would become thiasis bulbi if I left them without tamponade. So what I've done in them is use 5000 centistokes heavy silicone oil, 5000 centistokes. Why heavy? Because it doesn't emulsify that quickly. And on several occasions I had to change. After a year or 2 years, I removed the old oil, emulsified oil, and injected fresh silicone oil. The vision was sustained and retained and sustained for several years in these young children, so long I was following them up. Okay, so that's the only lifeline available to them, silicone oil. The aqueous secretion is there, very little. It's not enough to maintain the contour of the globe, maintain the pressure. It cannot raise it to 10 or 12 millimeter on its own. But if we fill the globe with silicone oil, so that now you need only a very tiny amount of aqueous to keep the tissues healthy. Okay, so that's what we used.
And in AR and RD cases, should we inject oil or should we take AR and retinal detachment?
Oh yes.
Sometimes without that laser.
Patients of acute retinal necrosis, we use all the time silicone oil. The problem there is that these patients are phakic by and large. Okay, so there is an issue with the development of cataract in these patients. I like to use it for just a few months, 2 or 3 months, You know, removing oil when it's still not emulsified is very easy. But once it gets emulsified, those droplets which are formed are impossible to remove ever. And they lead to glaucoma, they lead to retinal toxicity, and so much so. You know, but we should be mentally prepared and be ready for cataract surgery. The example I have shown you, he was treated with silicone oil, went on to develop cataract, he did the phacoemulsification, he got his ultimately the oil removed, cataract removed, 6/6 vision with a procedure for intraocular.
You prefer 1,000 or 5,000 in those cases? Air and RP?
I think it's just your choice, because 5,000 in these patients would be, we are using it for just couple of months. So there's no gain of using 5,000 centistrokes, which is difficult to inject, more difficult to remove. It's very tough to remove. So in this, because I'm looking at a short tamponade, I would use 1,000 centistrokes.
And sir, in suspected malignancy cases, when you do diagnostic vitrectomy, is there a risk of dissemination over the conjunctival
No,
surface?
no. For lymphoma cases, no, there's no risk of. The only risk people have speculated is maybe there is some sense in retinoblastoma. Okay, retinoblastoma, when you are doing any diagnostic procedure, when you are putting a needle, people do a cryopexy with the hope that the cell will not, when you withdraw the needle, cell will not walk along that track and come into the tissues. Okay, so they kill them with cryopexy. Cryo is a very, I used to do a lot of cryo, almost 40 years ago or more, for peripheral retinoblastomas. It's very effective, it kills all these, tumors.
It was proposed for intermediate uveitis also by someone.
Yes, for intermediate uveitis, now at the moment, no cryopexy for periphery. We go straight, either use immunosuppression. If immunosuppression is not helpful, we go in surgery. I'm very happy to do surgery for intermediate uveitis. They are the best cases. But in children, we are a little, careful in doing these surgeries. We don't want to rush into doing surgeries. So these are major interventions. Surgery is a major intervention. A deep thought must go into planning and discussing with the parents and the patients. What all we are going to achieve. You have to have very clear goals. What is the aim of doing surgical interventions?
And sir, in endophthalmitis cases, sometimes when there is not a 24-hour OT running, sometimes patients land up in the emergency and they are advised immediate tap, which you told that we should not go for. What is your opinion?
No, I'll tell you that endogenous endophthalmitis that we will typically see, they are not an emergency.
Post-op cases.
Post-op cases, yes. Okay, and if you do not have an OR running 24 hours, then I think you need to think about that. Because any facility which doesn't have an OR running emergency services, probably would not be able to manage these endophthalmitis cases even by daycare surgery or day surgery. So, because these patients would require surgery, trauma patients, so many of those would require surgery at night, other times. So you should have OR facility available. Those who are in kind of practice where there is no OR facility available, wait till morning, and if there is a panic, you could inject intravitreal antibiotics.
Only inject and don't
Inject and maybe do an aqueous stab, which of course the yield of bacteria is much less from aqueous stab. But that's what you can do if you don't have the facility for, then you will not have the facility to process the sample. Even if you draw the sample, you don't know what to do with it. So I think you have to be logistically prepared before you do any of these stuff.
Thank you.
So now we break for lunch. Thank you very much.
For lunch, thank you, Professor Gupta, once again.
Thank you.
Okay.
So for lunch today, we will do something different. The three professors will